Hello and welcome back to the Every Month Med podcast. We are super excited to be doing another podcast with Dr. Nina Phillip, who is Chief Nursing Officer and Vice President of Patient Care at Hoboken University Medical Center here in New Jersey. This episode, we are focusing on updated COVID information, including aspects such as the vaccine and the second wave. Before we introduce Dr. Phillip, we have some statistics for you. Worldwide, there are about 80.5 million cases with about 1.76 million deaths due to COVID. Currently, the United States, Brazil, and India are hotspots of the virus. Some ways to prevent the virus and the transmission of it are wearing a CDC-approved mask, washing your hands thoroughly for 20 seconds in hot water, and maintaining social distancing, which is about 6 feet or more distance. While these things are helpful and help prevent the virus and help prevent the transmission of the virus, other ways to be helpful are to donate blood because the U.S. blood supply is currently facing a serious shortage due to social distancing, and this is leading to blood drives being canceled. And if you've had COVID-19, you can donate your blood plasma. It is believed that donating blood plasma from a recovered COVID-19 patient can help a current patient who has the virus. These antibodies will help a COVID patient, and the way to donate your plasma is by donating blood.
So we also wanted to talk a little bit about the emerging vaccines. Currently, 2 vaccines are being produced by the companies Pfizer and Moderna. Both vaccines require 2 doses, each given at a separate time. So on December 11th, 2020, the FDA issued an emergency use of authorization for the Pfizer vaccine for people of 16 years or older. This expedited authorization allows for the distribution of the Pfizer vaccine in the United States. After studies have been conducted, it has been established that the side effects were more prominent after the second dose of the vaccine, and these effects include pain at the injection site, fever, headaches, etc. Pfizer has released that their vaccine has an efficacy rate of 95%, and they are also mass distributing their vaccines out to hospitals. Moderna's vaccine has also been approved by the FDA. Moderna's vaccine primes the immune system to fight off COVID-19 through 2 doses, similar to the Pfizer vaccine, administered 28 days apart. Although not stated for certain, it is speculated that the number of antibodies and T cells can drop. Early studies, however, have found that Moderna's vaccine provides protection for a minimum of 3 months. And based off of Moderna's clinical trials, the efficacy rate is 94.1%. And a little bit in contrast to Pfizer, they're doing a more controlled distribution of their vaccine. We would now like to welcome back Dr. Nina Phillip from our very first podcast episode surrounding COVID-19. Dr. Nina Phillip is the Vice President of Patient Care, as well as the Chief Nursing Officer at Hoboken University Medical Center. Without further ado, welcome back, Dr. Phillip. We are super excited to have you here.
Yeah, it's really exciting to be back. Thank you very much for podcasting this, especially current medical conditions that you've been doing. It's been great to see. And as I mentioned, young people taking an interest in healthcare, and hopefully we'll see the world a different place a few years from now.
Yes.
Definitely.
All right, so we're going to start off with some questions. So how has the personal protection equipment been? I recall from the last episode, you were saying that there's very limited PPE, and I just want to know if there's a little more and in preparation for the second wave, which we're going through right now.
Right. So right after, or soon after, the first wave, things settled down, and there was issues and with production also and distribution. However, with a lot of stimulus going towards PPE production as well as distribution, our supply chain has been very actively engaged in getting supplies. It had to be legitimate supplies because there was a lot of manufacturers of third party cropping up and distributing stuff that wasn't perhaps of the right quality or measurement according to what the CDC or NIOSH approved masks. But right now, so we had to source it from the right place, and making sure we had the right N95s and PPE protection for our staff. So we've been shoring up to make sure. And right now, we have been using, like, say, the gowns, the masks, surgical masks, or if we have to use them, they're one-time use. The N95, however, is still an extended use protocol that we're using, that we're, the nurses and the doctors and techs wear it for about 12 hours. But, if it's soiled or they lose their seal, of course, we have to discard and we give them another one. So there's no problem in giving them that or exchanging it out of that one as well. And so right now we're looking at different manufacturers. We used to have a supply from one or two manufacturers. We have right now different manufacturers that are giving us different types of N95s. And we are also looking at reusable ones. 3M is now producing reusable ones, the PAPR filters that they're called. And so we're trying to get that one also for our staff.
Yeah, I definitely didn't realize how much logistics goes into the PPE planning and sourcing and distribution. It's a
massive effort. Yes, yeah. Starts off from the manufacturing. You have to have a distributor, and it has to be approved. And then you have to fit test all your employees. So you have to make sure that the seal and the fitting is right, because everybody has different face types and shapes. So you have to make sure that you're not smelling anything, and even with movement, you're not having any issues with that any airborne particles can seep through. So, we do the smell test and making sure everything's okay. And the exercise test also to make sure that, as you're moving your head around, the seal doesn't break. So just to keep your employees protected, and you want to do that, especially when they're in contact with not just this, but any airborne particles.
Right, yeah.
Definitely. So our next question is a little bit broad. We just wanted to know, what do you think about the COVID vaccine?
So this is a new technology. Obviously, this is not something that we have ever experimented with, but this is something very new and it's very unique, and it is actually at the forefront of sciences. It's been great because you're not getting the live vaccine. It's not, the fear always has been with the public and with healthcare workers as well, am I getting the live or the attenuated form of virus? And you're not. It is a new technology, which is the messenger RNA. It is, like one of our doctors described it, as a personal trainer for your very own personal trainer. So that analogy is really, really apt to this. Yeah. So it's almost like, training your body. So your cells learn how to fight. It's about creating those protein spikes, as you've studied, and getting that message to your cells, so your cells can learn now how to fight off the viruses.
Yeah. So I have a quick follow-up to that, and it is: do you think that the goals for the vaccine distribution will be met? And if so, who are the first people to get the vaccine?
So it's very prescriptive in how the government wants the first line to be. So with the production, the way it is only slated to give to the first phase 1A, which is your healthcare workers, frontline healthcare workers. And so the frontline healthcare workers would be anybody in the hospitals, anybody in long-term care facilities, doctor clinics, dentists, anybody who's working in federally qualified healthcare clinics, for example, who have a potential for exposure to the COVID vaccine from the public. Anybody in, all of these, frontline work, dentists, for example, they're also frontline healthcare workers that need to get this. So there is a large impetus in making sure that the healthcare workers who volunteer, it's not mandated because it's still a personal choice to get it. Everybody, depending on their, knowledge and their comfort zone, can opt in or opt out of the program. So, first is to make sure that they get that, and to get the frontline workers in. And in our own hospital, we have created a strategy, which is, making sure who gets the prioritization. So the prioritization and the guidance comes from, for us, because we're part of New Jersey Department of Health. So very prescriptive in the sense that who you need to prioritize, even within your healthcare facility, who gets it first. So for us, it was to make sure that people in the ICU, in the emergency room, in COVID units, med-surg units that have very exposure to it. And it didn't matter what the role was. It was, nurses and techs, patient care associates, physicians, respiratory therapists who are in frontline, any physical therapists who might come in contact with, even EVS, which is environmental services or housekeeping, will go in to clean the rooms. Any persons that are going into the patient's rooms, for example. So they're considered priority one. And so to make sure that these units, these nurses, these healthcare workers did get that as priority. And then would be the secondary or tier is other units that are, for example, COVID-free units, nurses and doctors in there that go in and get that. And of course, you want to make sure that anybody else and have a potential for the frontline teams get that. And of course, the third and the last would be anybody who has had somewhat exposure, or potential for exposure. So that's what you want to prioritize and make sure that you get it. So we have right now, the way we schedule it in our hospitals, we do it that way. We open up prioritization for the frontline workers, frontline units. Then we open it up on a tier 2 to fill up the slots, and then tier 3. So there is a very prescriptive effort into making sure that, people do get it. Of course, there's, the initial week, which we received it last Tuesday. It's going very well.
Good, yeah.
The Moderna vaccine. So it's going very well, but, we want to make sure that, people who are hesitant, for example, they're waiting to see what's happening, they don't want to be the first ones to get it. So there's always that fear factor, but then, as they see more and more people getting it and they're seeing what their reaction is there any side effects? Is there, an extensive side effect, which shouldn't I take it? So more people are now, by the end of last week into first week, there were more signups, for example.
Yeah, that's super interesting to hear, because I knew that there were CDC guidelines in terms of who would be getting the vaccine first, but I didn't realize that within a hospital, there would be even more protocols. And that's just really interesting to hear about, I guess. Yeah, that was really interesting.
Yeah, so you don't want to give the vaccine to somebody who's working, obviously, in an office, as opposed to making sure the limited vaccine comes out and it's given out to your frontline people who obviously deserve it and want to make sure that they're protected because of their level of exposure.
Yeah, that makes a lot of sense. So our next question. The first wave we saw in a little bit of a different time in terms of weather. So our question is, do you think that winter is going to cause a spike in COVID cases?
You are seeing it. So as you can see, the numbers, the numbers are going up because of the winter time, because we're seeing where it's not the mass indoor gatherings that are probably, are limiting, because right now the restaurants are closing down. They don't have, they're limiting indoor dining. So outdoor dining is not something that's permitted. So not a lot of people are going out to eat, but they're gathering indoors, right? So they're taking it and putting them indoors in their homes. We're seeing some people hosting parties outside their their zones because you don't know who that person is and getting in contact with. So now what we're seeing is a cluster coming out of homes and indoor gatherings that is happening, and that's what's causing the spike among what the population is. So you combine it with the influenza, which it's interesting to see the influenza rates. It's not as high as what years ago, mostly because we used to, about now, I mean, we're still in the green because we get out like color coding on the influenza rates across New Jersey. So we're still, where we're not in the danger zone. And just about now, or in early January or February 2 years ago, we had this massive influenza people being afflicted by it and coming to EDs and stuff like that. So we had a lot of people, but I think part of that is what we're seeing this year, which is interesting, is because I think a lot of people also are being careful. They're, learned through this COVID vaccine not to clean their hands, making sure they're not touching their face or their nose, making sure that they're using good infection control practices. They're actually masking for the most part, so there's a lot. It's helping control the influenza, epidemic or pandemic as well. So whatever you want to call it. So it's trying to decrease that as well. So, we're seeing that, but like the mix of, it's hard to see during the wintertime because both do appear. Their symptoms are kind of very similar initially. So some people might ignore it for being a flu or vice versa. So you have to be careful and making sure that it is, differentiated and make sure when they come in, you're able to diagnose it and able to put people in isolation or quarantine early enough so the spread is not there.
Right. So I have a quick follow-up question to that. And it's like, how do you think people are going to be able to differentiate between COVID and the common influenza because they're very similar in symptoms?
Yeah, it's sometimes very hard, but it's only, usually the initial symptoms are very hard to differentiate because, you have a fever, you have body ache, you have, only thing that we know in COVID is the loss of sense and taste and smell, but sometimes that's early on or later on that people experience. But we want to make sure that's why, when they do come into the hospital, we do what they call the BioFire test. BioFire it's like a panel of viruses that we test for, and making sure that we eliminate all of them, whether it's influenza A, B, or COVID, and so it'll make sure which one which one do they carry and they're suffering from, so then we can quickly treat them better. That's why we kind of are encouraging also people to take the influenza vaccine because it helps control that. So when they do get these symptoms, it's easier to kind of say, oh, I've had the flu vaccine. It's a differentiator for people and making sure at least you're not succumbing to, and you're not playing a guessing game.
That's super interesting, especially the part about how like taking the influenza vaccine could actually help to differentiate between what was like potentially contracted.
Yeah. Especially because you don't know what the strain of the influenza is going to be.
Yeah.
Right.
Yeah.
Definitely. So our next couple of questions have to kind of do with the second wave and differentiating with the first wave. So the first question is, what is different about the second wave compared to the first one?
So what we're seeing on the hospital side with the second wave is with these patients are sick, but they're not as sick as they were before, or don't get as sick and the high mortality rate is not there. So we were preparing from, unlike the first time where a lot of our patients ended up in ICUs and we had to open up a lot of our ICUs, we're kind of were preparing for that, kind of opening and making sure we had expanded ICUs capabilities in our hospitals, making sure we shore up with ICU nurses or ICU skilled nurses, and to open that up. What we're seeing is a lot of our patients are still in the medical surgical unit, and we are managing them with their criticality, but it's not as critical as they were during April and May. But we are managing some of their symptoms a little bit better, because the first wave, we were very intent on making sure we restore their respiratory functions. So we were closely watching what they call an oxygen saturation levels and how the respiratory status was. And we were afraid for that to extend or worsen. And so would intubate a lot of patients, put them on a respirator, found that wasn't what was, in fact, they increased their mortality for, if anything else. So right now we're watching these patients. We're not as so quick to intubate our patients. We are starting them on the remdesivir and the other protocols as well, steroids. We're putting them on combination therapies, making sure that, if they're it's applicable for the plasma, they're candidates for the plasma, they get that as well. So a lot of other therapies that we find, we are instituting them early on, as opposed to the last time we weren't sure what would work and what wouldn't work for some of these patients. So it's almost like throwing the kitchen sink at them and say, you know what, we don't know what will work. Let's try all of this or in combination with others to find it. But now we're a little bit more smarter. We find what we learned from different, not only from ourselves, we learned from different hospitals, what worked. So there's defined protocols and order sets that we created. So every patient is treated similar, in how the protocol are standardized a little bit. Obviously, you have to allow for variation depending on what the patient is undergoing. We are trying to make sure that we are, these order sets have different variations of what would have worked, and protocols or clinical care factors that would have worked early on from the last time. So we included in them. So even if you had a different physician taking care of them, from the hospital side, we're providing almost like a guidebook for them. It's like a guidance for them to say, some of these are what was worked on the last time. So can we use this? And try and use some of these therapies that seem to have done so much better for our patients last time go around. So those are in like what they call order sets, built-in order sets and protocols. And clinical care, that's almost like guidelines for our physicians or our mid-level providers. Whenever they come in, this is what you do, this is what you order, this is what you would treat your patients with.
Right. So I know you touched up on this, but how have hospitals prepared differently for this wave compared to the first wave?
Yes, so a lot of that has, is multiple factors. There's a lot has to do with, let's start with physical controls, and how to manage the transmission of these patients. So a lot of our hospitals, some more than others, have created new ICU units. For example, I've heard of hospitals that have done that. They have actually worked on transforming their air systems and making everything negative pressure. So we've brought in, ours unfortunately is like an older hospital building. So we've had to invest in what they call HEPA filtration systems in many of our so we developed those things as well to make sure they're in the negative pressure areas or rooms that a lot of this airborne particles is, it's not going through the main circulation system. It's taken and thrown out, for example, filtered and thrown out. So a lot of that, and a lot of hospitals have worked in expanding, for example, ICU systems, buying more equipment, to manage these patients, whether it's investing in buying more respirators. Right now, we've invested in buying more high flow machines because it's not the respirators, it was the high flow machines, which is oxygen delivered at a very high pressure. So we're going to make sure a very high oxygen concentration for these patients, which we found have better therapy and better outcomes for our patients as opposed to just putting them on a mechanical ventilation system, right? Like as you see in the respirator that has the tube in the mouth. Yeah. We wanted to make sure that these patients still had a mask and the pressurized oxygen was going in. And this way we don't have to really go in and intubate our patient. So there are physical controls, like I'm buying more equipment, from more catheters and lines and invasive lines you need to put patients in. We needed to get more monitors to make sure that the patients who are sicker were monitored because we ran out of ICU capabilities, so we had to get more monitors. So we have to get standalone monitors and making sure. Then, of course, there's other controls that we have to take, like administrative controls. You want to make sure that we have protocols, policies, standards of care, education surrounding COVID-19, making sure our staff is up to date on a lot of these. The last time we deployed resources from multiple parts of the building to these COVID units, and a lot of these nurses and docs who are not familiar with taking care of patients with such, because you can't expect a nurse who's taking care of OB patients or babies to know how to take care of COVID patients. Because we had lack of resources, we deployed a lot of resources from different parts of the hospitals to kind of do what they call in nursing team-based nursing. So even if you are not, like say, a medical ICU nurse or a nurse who's very highly specialized in taking care of such patients, you could have the assistance, and because there's a dearth of them, you could have an assistance from another person, but in what capability or form can they help out? Maybe they can help you give medications, or they can help you move a patient, turn a patient, feed a patient, do care for the patient, actually without really understanding how to manage the monitors and the ventilators and the medications and all of that stuff. So it's the IV medications. So it's a little bit more complex and highly specialized only for that particular training, like critical care or medical surgical nurse. So we had to make sure that our nurses and techs were now trained to handle the second wave. So a lot in between, where we got a reprieve during the summer to post first wave and in preparation for the second wave, we had to make sure a lot of our nurses were trained. The second part of it also was to getting additional help. The first part around, we were, by the time COVID hit us, it was kind of hard because we had to make do with a large number of patients with a very short number of nurses and doctors. This time around, we had to prepare ourselves. We said, we're not going to be going through the same trauma. We can't be waiting for the wave to hit us. We have to start shoring up our human resources and having enough people in compared to the last time. So we contacted these agencies and traveler nurses to make sure that some of the nurses would come and start working for us ahead of the second wave or be there in time for the second wave. So we kind of had to time it in a way to say, okay, we're watching our numbers go up or down, and depending on how it is, we'll start to bring in people to help us assist. And so this way, our nurses don't get overwhelmed, because you have to also understand, in addition to the patients getting sick, there's community spread, and the community spread could be happening within healthcare workers. And so the nurses and the doctors, if they're exposed to their family members or their friends, are going to get sick. They're going to go down and they won't be able to work. So where do I get the staff from? So you have to make sure that you still have to run a hospital. You still have to have good amount of resources to make human resources to make sure, and the right kind of human resources. You have to make sure they're skilled and are competent in a certain number, a certain specialty in order to provide that level of care. because right now with the second wave, we're still doing surgeries, still doing our diagnostics. We haven't shut it down yet. So the complex factor here on second wave is we're running both. Previously we shut everything down because we really couldn't handle the deluge of patients coming in. And so we didn't understand the virus. We didn't know how to manage it. And we wanted to make sure that the rest of our patients kept safe. And so we shut down, and we had to use whatever beds were available to maximize it for example, surgical units. We had to convert it completely into COVID units. We had to take up those beds. Pediatrics, we had to completely take that over. Maternal child, we had to completely take that over and say, our long-term facility, we had to completely take that over. But right now, we're trying to maintain both services. We're trying to maintain our outpatient services as well, and making sure that we're still conducting surgery, and we're separating those. We have separate elevators for our patients, surgical patients. We have separate pathways to make sure that we're separate units. The nurses taking care of them don't have exposure to COVID patients. They're very separate. So healthcare workers are very, very segregated, and make sure that they're not exposed. They're tested frequently. And so testing has been a great help this time. So second wave around, we have faster testing, right? Testing capabilities are big.
Yeah.
So we have turnaround time is 45 minutes. So some tests. So these tests, having a quick turnaround, we can catch them early, we can diagnose them early, and we can isolate them early. Before, we had to wait 2 and 3 days for results to come back. So that was a big piece in not knowing whether or not they were positive or negative for a very long time. They were suspected, but do I start a treatment on a suspected patient? Could be another presenting symptom. I don't know what's going on with this patient. So testing early is a big factor, and starting the treatment early is a big factor in a lot of our patients doing much better than they were the first time around.
That's good to hear. That's very good
Yeah.
to hear.
The turnaround really shrunk from 2 to 3 days to 45 minutes. That's a big jump, definitely.
Yeah.
So our next question is, how do you think that post-holiday travel is going to affect COVID and its transmission?
Yeah, that's what we're afraid of. And, unfortunately, we have to prepare for that as well. But, that's why a lot of, public health officials are often warning other people, be careful with holiday travel. Please don't travel if you don't have to, and have personal and a civic responsibility towards the community. This time around, unlike the last time, we got help from other parts of the state, because other parts of the state were not experiencing the trauma that New York and New Jersey and Pennsylvania was having on the first wave around. And so we were able to get our nurses and doctors from different parts of the country. This time around, it's very hard. Very, very hard to get additional agencies. So even though we've tried sourcing, it's very hard to get them to come in to work, because they've been utilized by other hospital systems in other parts of the country. And so these travelers are very engaged, and right now they're on an assignment somewhere. So to get them to come to New Jersey, where other parts of the country are also grabbing for these scarce resources, it's kind of hard. And so when healthcare system breaks down, it's not, you can have 200 or 400 hospital beds, but if you don't have the staff to take care of them, you practically have to shut your hospital down. You have to close your doors. And so where do these patients go? So you don't want to ever, and that's why the state or the nation or CDC always, they get our numbers, they're always watching how many hospital beds, staffed hospital beds you have, because you have to make sure that, yes, hospitals have the capacity to take care of these patients coming in. And so we don't want to get to where we were first time around. There's a lot of trauma associated with healthcare workers workers having to have seen the first trauma from seeing so many deaths, from seeing, and their own family members also being contracted with COVID, and their own coworkers being contracted with COVID and dying. And so that trauma still sits with them. So to have to go through it again, there's a lot of people saying, I don't know if I want to be around for the second time I'm around. But, we tried doing a lot of work with our teams and our employees and our management staff to try and build up what they call resiliency, training to make sure that our staff has somewhere that they can, someone they can talk to, somebody they can rely on, somebody to shore up their resiliency, resourcefulness from among within and outside, so they can fall back on something when stress hits them. So we're trying to minimize the stress on them, but you have to make sure that it's not constant trauma that's people's affecting them, and you don't want to create burnout, or you don't want them to be sick and fall sick from all that. So you have to implore your public to make sure that they keep safe, so you do the best that you can. Hopefully good sense, proper sense, and care for each other prevails. Better sense prevails, and making sure that, but I do understand that, people are tired of sitting indoors. They are tired, but right now we're going through a pandemic. I can't, I don't know what to say.
Yeah. No, it's good to hear. It's a teamwork, not individual, teamwork.
Yeah, you have to kind of, none of us in healthcare in the hospital could have done it without leaning on each other, whether it is for emotional support or for support for each other. So every single person, doctor, nurse, therapist, tech, housekeeper, maintenance worker, people in the morgue, in the lab, everybody in the community in itself. So it was such a combined effort to help us get through the first wave, and we're trying to hold that up, but people do become, after a while, it's just, I don't know if it becomes that this is what it's expected to be. And so I hope this is not the norm, but there were good things. I do have to say there's good things that came out of that. So when you look at, how do you build resiliency in your teams, is to first look at a good side of what healthcare has changed into.
Yeah.
Healthcare is evolved and has evolved, and healthcare workers have evolved. Yes, there's trauma, but through trauma, we've learned how to be more agile, be more flexible, adopt technology better, position ourselves where, we perhaps can combat other communicable diseases in the future, and what we can do to make things better. Understand that we're not alone in this, and then healthcare is not a hospital issue or a clinic issue. Healthcare is a global issue. It's an everyone issue. And so we need the global community to kind of assist with wellness, making sure people are healthy and well, and to adopt good, healthy practices in order to stay healthy.
Yeah. So last question for you. I don't know if you've been hearing strains in the UK and in South Africa now. How do you think that's going to affect the US or just overall in the world?
So it's kind of too early to tell what these strains are, and still trying to digest some of this information. But it wasn't surprising that this happened, that there would be other strains of it, just like, for example, influenza the viruses have different strains. And so going forward, I'm not sure if this is going to be our norm and this is going to stay with us for a while. And having these different mutations or strains of the COVID-19 vaccine, just like the influenza vaccine, the viruses. and having to us to develop, such. And we don't know if the same messenger RNA will work, so we have to decide if that is, perhaps this technology is different. It could be similar and it could work with these. We don't know. So there is, the fact that we're in this on the second wave and say, what is that doing now? What will it mean? Right now, it's just too early to say, and we hope it's not, but I think we'll get through this. I mean, just like we get through the first one, we'll get through the second one, and or the third or the fourth strain, who knows? or any other variation of mutations of such. But, I think this is also a part of nature. Not, a lot of people hate to say it, but, some people think it's natural selection. It's nature correcting itself, overpopulation and the supply versus demand. And so there's a lot of controversial philosophical way of looking at certain things and saying what is happening right now, is course correcting, what is in the world that's happening today. There's a lot destruction on destruction on natural resources. So Mother Nature is course correcting itself.
Yeah. That was all of our questions. So thank you so much for taking the time out of your busy schedule to come back for another episode of Everyone.
Thank you.
And
I hope the information was informational and useful to your viewers.
Yes, it definitely was.
Okay, good.
And thank you everyone for listening in on another episode. We hope you guys enjoyed it. And as always, please leave a comment if you have any suggestions on any upcoming episodes. Remember to practice social distancing and always wear your mask. Happy holidays, everybody.
Yes, vaccines doesn't mean that it went away.
Yes.
You still